Right, well thank you very much. I'm going to put you out of your suspense and talk to you today about My QuoL-T, which is a project about a new approach that we're doing to improve communication and collaboration in healthcare. My name is Nicky Harris and I am a paediatrician by trade and a palliative care paediatrician working for the Children's Hospice Southwest at the moment. But prior to this, I worked in paediatric oncology for 20 years, so I've seen quite a lot of oncology over my time. This was based in Bristol and in a variety of shared care units in the Southwest. But I also bring to this discussion the fact that I have been a cancer patient, so I have also, as well as seeing a lot of oncology, I have lived it and felt it. So My QuoL-T, what are we talking about here? Well, it's spelt in a funny way because it stands for Measure Yourself Quality of Life Tool. And it's loosely based on something called MyMOP, which is a general practice tool, stands for Measure Yourself Medical Outcomes Profile. And the background behind MyMOP is that essentially you go to your GP, say with a bad back, and they will talk to you about the pain and how bad that is, or what impact does it have on you in terms of your daily abilities. And they set up a scoring system, they mark it, and then they give you some treatment. And then next time you come back for your bad back, they then compare how you're getting on, so they can see whether the outcome of that treatment has helped things. So it was that principle as one of the things that we were looking at in terms of children's hospices, because what we're trying to do is improve patients' quality of life. But it's actually very difficult to measure quality of life, and we didn't have a good tool to do that. So that was one of the things that we were just sort of playing around with in our minds. And when that happened, when we were doing that process, then in 2010, I had to take an enforced year out to have my grand tour of oncology myself. And I had the luxury of having some time off to play with some of these ideas. And what I did while I was on chemotherapy is I MyMOP'd myself. And this, it doesn't make much sense until I explain it, but this is my first 3 cycles of chemotherapy. So that when things were on a normal keel, I was on that middle line in the middle there, but I was getting pain and nausea and muscle weakness, and as those got worse, those levels got up. And I was also losing energy and sometimes very tired, and those were the levels that were going down. And I initially did this because I wanted to find my good days so that I could make the most of the time that I had, and then I soon discovered actually they were few and far between. However, but it did give a very visual image of what my treatment felt like. And the things that really made an impact on my quality of life were all the things that you couldn't easily measure from a medical perspective, because it was nausea, it was pain, it was weakness, it was fatigue. And there aren't easy ways to describe that to your healthcare professionals. And after all, I was used to oncology, I spoke the language, I wasn't fazed by the people I was talking to, it was familiar territory for me, and yet there were lots of times when I found that it was difficult to feel that we were on the same wavelength. So, holding that thought, we then thought, actually, if that's what it is like for me, and I can have a visual picture of what it feels like for me to be as a patient, can that help other families, children and families who are coming into our hospice? So what we have done is developed a system that allows patients and their families or carers to identify the priorities that matter most to them, to describe them in their own language, to prioritise them, and to monitor their own healthcare problems and the impact that this has on their quality of life. It brings together MyMOP with some computer wizardry and some techniques from social media, basically, to produce something that is web-based, interactive, easy to use. It's very much patient and family centred and driven by them, and it's controlled by them, not the professionals, which actually makes it quite unique. The advantages of it are, unlike the MyMOP system where you do your scales once and when you see your doctor, and then you do it again next time, but nothing actually in between. You can do this on all the time, so that you can monitor things when you're at home, and as you go through you can see changes as they happen. As you put information in, it generates a picture. I'll show you some pictures in a minute, but a picture is worth 1,000 words, and that's one of the things that the families have said to us that they really like about it. You can, a bit like Facebook, you can share those pictures if you want with the healthcare professionals who are looking after you, but that's under your control, so you can not share if you choose to as well. And there is a system built into it for early reporting of significant problems, so that if we have someone whose pain we're looking after, for instance, at the hospice, and they start scoring their pain at 7 out of 10, that will ping off an email to us to make sure that we're on top of that. So it's an adjunct to more timely communication and timely support for the patients that we look after. So this is what it looks like. It's completely free, it's password protected, and all you need to get started is a valid email address. But before we do get started, what we do in the hospice is we sit down very often with a cup of tea, because we do have the luxury of cups of tea and time, and we sit down and talk to families about what their priorities are. And these may be something specific for the child, but it might be something that affects the whole family. For instance, the mother is very anxious, or the family doesn't get any sleep because their child is crying, or whatever it is. So it can be very specific to a child, or it can be a more generic family-centred thing. Once families have identified their priorities, we ask them to list them, and there's some physical priorities just listed down there, and also some emotional and social ones. But the most important thing for both of these is this bit here, which is make your own, because that allows you to put in free text, whatever you want to do. And the family of a young baby that I was looking after was saying, well, actually a toddler, well, actually we don't know whether, when he has these awful days, we just can't get him settled. We don't know whether he's tired, whether he's bored, whether he's in pain, whether he's hungry, but he has these whingy days and we can't do anything right for him when he has them. So that became whingy days. And you then describe that in your own language. So having decided what your priorities are, you then rate them on a scale. You can use just a basic one, from none, slightly, moderately, severely, or overwhelmingly, or you can put in details to make it relevant to you. And this one is a child who had cerebral palsy, whose parents were saying, well, actually we know he's not in pain when we can get him dressed and he doesn't mind at all, and yet when it's bad, he's screaming half the night or screaming all the night. So you can see how they get a sort of a rating scale built up, but it's what's relevant to them and reflects what's normal for them. What you then do on a daily basis is, there's a screen like this either on your computer, or it'll come up on your smartphone, and you just press that button, slide it across, and that puts in your score for the day. And these bits here reflect your descriptions that you put in, that I showed you on the previous slide, and the smiley faces to make it a little bit more user-friendly for children if they find that that's an easier scale for them to use. And when you put that information in, it generates a graph. And this is an example, for instance, of someone who had tiredness, pain, and a not very good appetite, started some regular painkillers, and you can see that the pain came down, tiredness got better, appetite improved a bit. Unfortunately, he didn't hold it, so you had to change the doses of those, and by the end of this here you can see that their energy levels have come up, pain levels have gone right down, and the appetite's improving. And so you can see how things are going. So from a medical point of view, you can see the progress that is being made. Now, that one was a demonstration example, but the following ones are all real examples. This is a child with epilepsy, and these comments that are put in here are the free text that the mother has put in when she was filling this in. So for this example, for instance, there were times when he was fitting much more than normal, but there was an intercurrent illness there, and that's what was triggering this off. And there were times when he was fitting much more than normal, and there wasn't. And from our perspective as doctors, we're going to be approaching those in different ways. So it's a way to help us to get the treatment right for what's going on with this child. Here's another example. This child had cerebral palsy and leukemia, had a lot of things going on here. We had pain, we had sleeping problems, we had muscle spasm, and you can see that there are very few good days in here. But one of the things you can do with this is separate out and look for various patterns. And we thought that a lot of the pain was coming from spasm, and initially they seemed to mirror each other very well. But then it becomes clear that actually the pain sometimes is much worse and the muscle spasm isn't there. So something else must be causing that pain. Now, we could have found out that if we had done enough discussions and so on with the family, but when you have a child with a lot of symptoms going on, it's sometimes very difficult to untangle all of that information. When you see it on a graph like that, it looks barn door obvious, and it stopped us from pursuing further anti-spasm treatment and doing the right investigations and getting on top of this. And this actually turned out to be a gut problem and nothing to do with his muscle spasm at all. So it does help us to provide better treatment, and it's all down to clarity of communication. Having done that, what you can then do is add up the various scores that you've got to get some sort of a cumulative information on improvements or response to treatment. And because those are the priorities that an individual has identified that make a difference to their quality of life, it's actually produces a quality of life score that's relevant and meaningful to them. So going back to my example with my MyMop, for instance, these were my cumulative scores when I was on chemotherapy, cycle 1, cycle 2, cycle 3, cycle 4. I was really struggling with mine. So they reduced the doses. You can see it made a huge difference, and unfortunately it didn't hold it, and then we abandoned chemotherapy. But as a way of keeping an eye on how patients are tolerating the things that are happening, actually it's a very easy visual way to see that. This is another example, and this one was done on a daily basis. This is a child who didn't have cancer, but who had a variety of problems going on: pain, seizures, breathing problems, nausea, feeding problems. And there were good days and bad days, but over time you can see that the good days became gradually less good, and further apart as well. And actually by the time we're down here, we're really running into problems. And what this did for us at the hospice was that, because this child was at home, with her mum looking after her at home, she'd been in and out of the hospice a number of times, but when our staff were able to see this, it alerted them to think, actually, this mum needs more support at home, and we actually offered her an earlier admission to help sort things out. So by looking at these patterns, you can have more timely intervention and more appropriately manage all the demands from your caseload, because you can see who's doing okay at home and actually who's really struggling. So I talked about the sharing. That's done very much like Facebook. Essentially, if professionals sign up on the system, their names appear, you press the press the green cross, and they turn up on the people who can see your list, your graphs. And if you, as a patient, decide you don't like them, you press the minus and they're out. And it's entirely up to you. It's not the professionals who can nip in and see your graphs. If you've decided they should be private, then that's your call. What the professionals see is a list of people who've signed up on the system, and then when they press view, they can see those names and view those charts. So, but they can't change the information that's putting in. It's very much controlled and led by the patients themselves. So we've had quite a bit of feedback from the children and families who've been using this over time. This is a quote from a parent of an 8-year-old epileptic who said, actually, I love this, I love the graphs. I take them into clinic instead of having to remember what happened every time I adjusted the doses. And her description was that we go to clinic, we only see this consultant once every 4 or 6 months, something like that. And then he'll say, oh, now last time we adjusted the dose of this, how long did it take for that to work? And she said, and I can't remember. It feels like it's a test that I have failed. I feel like I have let down my child. And that's awful. It shouldn't feel like that, but I must admit, even though I found, as an oncology patient with oncology knowledge, that I thought outpatients would be easy, it was one of the very difficult things to do, to make sure that everything that I wanted to say did get across. And otherwise, it was a clinic where you just thought, oh, that failed. And sometimes they just didn't get it at all, which was not good. Anyway, this was a cancer example. The doctors wanted to know about things they could count. I'll let you read this. I wanted to tell them about what I could feel, but they just didn't seem to hear that. When they saw it on the graph, it was amazing. They finally got what it meant for me. And that's going back to that power of a visual image and to aid communication. This one from a mother of an infant with a neurological condition. She said, oh, I love this. I do it in the evening on the app on my phone. It's really, really quick. It's even quicker than the adverts on the telly. I just punch it up and go, zip, 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 that's it, done in the day. Which, well, you laugh, but actually for a lot of quality of life assessment, they might be, 30 question sheets that people fill in. This is 30 seconds. But she went on to say, but I feel safer at home, less isolated and more confident, knowing that my hospice nurse can keep an eye on things too, but also feeling that I'm in charge and I'm doing my bit for my daughter at the same time. And that taps into the comments that were made about things about control and empowerment of patients, because that bit, being able to know that you're doing your bit, is really important as a parent. This is one of my colleagues in the hospice who said, actually, when children come into us for respite care and everything is very complicated, they go home with a plan and then we hear nothing from them for weeks perhaps until they come back from their next respite stay. If you know what's going on, it's actually really helpful and can help us to learn and improve the care that we deliver. And this is from a community paediatric colleague of mine who said, who tried this out for us, and she said, actually, when I saw this lad's name on the list, I thought I knew what we'd be discussing. When I asked his mum to prioritise the symptoms that she felt were most important, it was like we were talking another language. And she goes on to say, I hadn't realised that we saw things from such different perspectives. And to put this into context, she is actually somebody whose patients think she's wonderful because she is known as being a very good listener and a very good communicator, and she could see the value of using something like this. So, I'm nearly done. The next steps with this are that we are going to continue to work with children, young people and families and incorporate their suggestions into the design of this, and to introduce the concept to healthcare teams. If you want to have a look, that's the website, and I did think that over the tea break I brought my laptop, and if we can get Wi-Fi access, we can, if somebody wants to play with it, we'll get it set up here. But we're also very fortunate in that at the end of last year we got funding from the Health Foundation, part of their 2012 SHINE projects, to looking at innovation in healthcare, to get an independent evaluation of how this works in practice and the potential benefits that it could provide. And so what we're doing now is a project only just started from April, and it'll run for a year, to look at how the website is used, but also try and get feedback from the families who are using it about, does it improve the quality of care, how does it impact and hopefully improve communication, collaborative decision making and aid empowerment of patients at the same time. So I'll just draw to a close there, but I can't possibly stop without saying a huge thank you to the patients, families and staff at Children's Hospice South West, because without them this wouldn't have moved forward at all, and Department of Health, Marie Curie and the Health Foundation for their funding. Thank you.